everyone, it's Ashley Koff, registered dietitian here with the Better Nutrition program on a snow day. I don't know if you can see it's still snowing outside of my window. And this is the Better Nutrition program expert interview series, which I personally, it's like my favorite thing to do because I just love learning from experts just about the different ways that they dive into and tackle nutrition and health issues to help us all get better. So today I'm joined by Julie Dillon, so I'm going to call her Julie Dillon so I don't get tongue twisted in there. Dietitian, North Carolina, right? Which is, so I went to college in North Carolina and my parents live there. So we have a strong North Carolina connection. And I cannot tell you how excited I am about this topic because it's one that is so important, and it's so important to get expert advice on. So we're going to be talking about PCOS. Julie and I were just talking, that we branded this as PCOS and fertility discussion. And obviously for people with PCOS, there's a fertility conversation, but we might not be able to dive into the whole story on fertility. So I think I'll probably just end up bringing Julie back to have a whole conversation on that one. But Julie, before we get started, I always like to introduce my guest and just share a little bit about your non-nutrition stuff. I love to find out what makes people laugh. And so when I asked in my pre-interview, you said you love that your kids love to laugh about burps and farts, which I feel like is so ageless, right? It's like I still laugh about burps and farts, but I love that part. And so maybe take a moment to just talk a little bit by way of introduction just about how you sort of came up with Food Peace Dietitian and kind of who you are today.
So thank you. And thank you for inviting me onto this. It's really nice to connect with you, Ashley. And the Food Peace part of my business and my journey was, I don't know, it was a rocky kind of twisted journey, but basically I came to this place where I was really wanting to help people promote health, but I found diets didn't work. So I dug really deep. I was a dietitian for 3 or 4 years, and I went back and got a master's degree in mental health counseling. And then I was like, well, now I can help people use diets because now I know all these behavioral things, and they still didn't work. So I decided to shift gears after I feel like I really then started to listen to my clients. And that's actually when I really started to work with the majority of people with PCOS, was right after this master's degree in counseling. And after listening to people over and over again say how little they were eating and how much they were exercising and how awful they felt and how ashamed they felt that they couldn't like change their weight, or they felt like they couldn't stick to the regimens because the cravings were just so strong, I heard myself like not believing my clients. And then I'm like, wait, can everyone really be lying? Like, there's no way everyone's lying. Okay, no, it has to be me now because I'm the common denominator here. So really when I started, I feel like, to listen to people more, I found, there's not a lot of tools out there for people to promote health with PCOS because everyone just is told to focus on taking away certain things and to lose weight. And so I really wanted to find something different. And so I think I found after studying with other people who were willing to not use weight loss as a measure of progress. And again, like just using practice-based evidence, sort of like listening to clients again about what works and what doesn't. And that brought this kind of food peace kind of journey to my eyes of like how it is a journey. It's not a destination, and it's helping people to become the expert of their body.
Oh, that's amazing. And I'm so grateful for it. I always say to people, like in my practice, I always say, like, I did not go back and get the degree in mental health, and I'm not a therapist and whatever. And so that's such a great lesson for us because I think, in therapy, you learn so much about how important it is to listen. And I think in dietetics, too often we learn stuff, we learn what's right. Potentially, and then we tell people what to do, right? And instead of listening. And so that's something I've had to learn. I'll put the ing on the end of that as I've gone through, and I just so admire you for getting that space. And I think in this particular, especially as we look at PCOS, such an important thing to look for. I love your materials because this really is, when you say about that whole journey, it's that whole person journey. I want to start off with what actually is PCOS, because I feel like I could do one of those like jaywalking, like, Jay Leno, like old things where you would go out on the street and I could actually ask doctors and dietitians as well as patients what PCOS is, and we would get some really hilarious, but also sad answers. So, why don't you start with like, what is PCOS sort of in how it's defined, maybe even how it's diagnosed, but then also like, what really is going on at the body level?
Okay, so I'm writing some notes to make sure I get all that in.
And
that's a really important question, because I think people think they know what it is, but it really, we don't all know. And honestly, it's a condition that is so poorly researched that there's a reason why we don't know, is because it's just this ambiguous kind of diagnosis of exclusion. But what we know so far is that it's an endocrine disorder that has metabolic and reproductive consequences to it. So I think a lot of people think, because the name is polycystic ovarian syndrome, that it starts in the ovaries, but it doesn't. It actually starts in the hypothalamus. The researchers are in a place where they're starting to try to find a way to diagnose it earlier and earlier, but technically right now a person needs to be at reproductive age in order to get a diagnosis officially. Now, many doctors now will diagnose it outside of that, but technically at this point, the Rotterdam criteria is still including some kind of diagnosis using those ovaries. But because of the metabolic consequences, it is a lifelong experience. One of the first kind of cues that there may be PCOS going on is a mood disorder in around puberty. So it's interesting to kind of hear people tell me
right there for a second, because who doesn't have a mood disorder around puberty? I'd love to see how that's you know what I mean? Something I think every parent is oh my gosh, is my child have PCOS? Yes. Right.
Well, okay, so mood disorders in puberty, as a mental health counselor, I know they present differently than I do for people who don't have a mood disorder at puberty. It does look different, but we all kind of have a mood shift. Yeah. I have a preteen in my house right now, so I totally understand that. But with that being said, the diagnosis officially at this point is 2 of 3 criteria, and one of them is having cysts on the ovaries or signs of hyperandrogenism, or signs of high testosterone or other androgens. So that could be more facial hair or hair loss on the head, something like that. And then the other one is having some kind of abnormality with the period. So maybe not having a period, or weird periods, or heavy periods, light periods, something like that. But you only need 2 of the 3. So someone may not have cysts on their ovaries and have PCOS. Someone may have completely normal cycles and have PCOS, which I feel like that's the kicker that not a lot of docs think about. And the thing about the real life story of it and I don't have PCOS, so I have to just name that, I don't have the lived experience. I feel really grateful over the last 20 years. Clients have really helped me learn, and I still am learning. But the experience tends to be one of kind of do I have this condition? Do I not? Because it is kind of ambiguous in a way. And feeling really tired and feeling just kind of a heaviness. A lot of times my clients, not necessarily heavy with weight, but heaviness of the body and having a hard time moving. And what we know with PCOS for most people, that they have a high circulating insulin kind of thing going on. So their body is feeling just exhausted from that. And mood disorders are really common because it does start in the hypothalamus. So depression, anxiety, ADD, bipolar disorder, those are all really common in this condition. And so sometimes because I work with people without PCOS, and so sometimes I'll be sitting with someone who feels it's carb cravings, which is also another common experience, and maybe their periods are weird, and then they say they have a mood disorder, and I'm like, we need to dive into this a little bit more. I wonder if you have this other thing going on. And, finding ways to treat it is something that has been really cool for my clients, because they find themselves reconnecting to their body, feeling energized again, and feeling just less chaotic around food, which I always think is a really good thing, to feel more at home in your own skin and to feel like food is actually fuel instead of something that keeps missing the mark. So.
So important, and I think I want to move into that, what does work and what you find and how you worked. And I love just how honest you were. You said you were going down this path, and you're like, oh, my client's lying, and then you're like, oh, I had to figure it out and really listen to them. I pretended to be in one of your clients' situations, and I went on and just started Dr. Googling and trying to see what people are talking about, and went to really reputable sources, a couple of the medical clinics around the country. And part of the problem in the diagnosis, as you said, is there can be some things that may, they could either be diagnoses for other things or overlooked or, not paid attention to. And then, the treatment protocols so I kind of grabbed, I'm going to just read for a moment. I grabbed a couple of the ones, and I see we're getting some guests. If you have any questions, please jump in, to the live and we will answer them, accordingly as we're moving along. Things like might just recommend weight loss through a low-calorie diet combined with moderate exercise, right? Even a modest change, losing 5% of your body weight, could be helpful. And then really the key recommendation was medication. So birth control pills, progesterone theory, Clomid, Femara, some blend to address the insulin resistance, metformin, glucophage, that kind of a thing. And then maybe medications to address the symptoms. So talking about if you're having hair or acne issues, how do we address that? Talking about if you're having hair loss, how do we address that? So it was medication. And so first of all, you talked about the food side, and we can certainly get into the low calorie diet, just a general recommendation of a low calorie diet. I think we can, definitely come up, with what's better than that part. So I'd love to kick off with your perception of and kind of how you address working with a client as they're getting the diagnosis. So let's assume, okay, we've got a pretty good likelihood or a good diagnosis here. What has been your experience with medications and also combining that from a food part? And we had Reed, who is a wonderful nutritionist from Florida, who said this is such a timely subject. It seems to be more of a problem every year, probably due to some of the hormone disruption stuff and other pieces. Okay, back to Julie, back to the question. Thoughts on, because I've had people say, do I have to take the medications? And I think that's when we look at this list, it feels like, especially for a young person, a lot to take on from a treatment standpoint.
Mm-hmm. So what I like to start with a client is to make sure that we're kind of on the same page on what even caused the PCOS, because a lot of doctors and healthcare providers will tell them that they caused it, that their weight gain caused it, or they weighed too much and that caused it, or they ate too much sugar or carbohydrate or something like that. And that is completely false, because we definitely see a genetic side to it. It's passed down through families. And there's also environmental components like you were speaking of that we're connecting to as well. Again, we totally do not have a clear picture yet, but we definitely see it passed down through families with some environmental stuff. So people didn't stand in line for PCOS, like they didn't cause it. Yeah. It's not their fault. And honestly, like that is such a big burden that so many people carry with PCOS that I want to make sure if they're listening that they know that it's not their fault. Mm-hmm. And it's not their fault if they haven't found what works yet, because I do find that a lot of the medications focus on the ovaries, like the birth control pills or the Clomid. Clomid is of course used to help when people are trying to get pregnant. And outside of like the fertility conversation, there aren't a lot of doctors who want to tend to PCOS. In the U.S. where Ashley and I live, of course, there are people who will find that there's some doctors that do, but especially in other countries, a lot of my clients that I've worked with in the UK, their doctors are like, just come back when you want to get pregnant, and just let it go. And I'm like, oh my gosh, you're going to feel so awful. Yeah. Yeah. And so that's part of what I really want people to find a way to advocate with as many tools as they can. And sometimes that means me getting on the phone or writing a letter if they're very far away to their healthcare provider to see what we can do. And, the treatment protocols do focus on weight and insulin levels. And I think especially as dietitians, we think in the very clinical kind of way about it. And we're like, oh yeah, we can help lower insulin levels or blood sugars by cutting out carbohydrates. And certainly when we do that, when we look at the research with PCOS, like the short-term research is really promising, but we have to remember that the long-term research isn't available, or if it is, the research in PCOS is, the numbers and the studies are really small. And a lot of the I have to use bunny ears. Long-term PCOS research is 12 weeks, which is not like how long that people are encouraged to follow these restrictions forever. So we need to study people forever, or at least a couple years. And so what I always think about is like our clients aren't robots. We have to remember that if you have PCOS and you try to cut out something and it feels awful, like as a healthcare provider, I need to do a better job of helping you to figure out how to feel better, and then see if there's anything you can do differently. And what I find is if we help people find tools to lower insulin levels, which may be medication, and it may be supplements, and it may be eating differently, or maybe sleeping better, trying to like maybe getting a sleep study or something like that done, that helps tremendously. And then the body kind of like syncs up. So then the food cravings go down. So then cutting out carbohydrates or something like that just becomes a moot point. It doesn't need to happen because things are being managed. And the interesting thing about the medications that you'll find if you like Google PCOS and some websites is birth control pills are the first thing that people are usually offered. And research over the last couple of years have found that there's a link with birth control use and PCOS and further increasing insulin levels. So
and I'd
it makes
imagine also, I'd imagine some digestive stuff, certainly has the potential. I actually came across one of those long-term studies that you were
12 weekers.
Yeah, in the recommendations from an integrative health standpoint, or a natural, like how to help with PCOS. And I was curious what you thought about this. They said one study indicates that caloric intake timing can have a big impact on glucose, insulin levels, and testosterone levels. In terms of women who ate their daily calories, significantly improved and they didn't tell what significantly was, insulin, glucose, and decreased their testosterone by 50%. Compared to women who ate their largest meals at dinner time. So the effective diet consisted of 980 calories at breakfast, 640 calories at lunch, 190 calories at dinner. As somebody who doesn't even believe in in the effects of calorie counting, I find this so challenging. I feel sad for anyone who's eating 190 calories at dinner, unless you're choosing to do it, and you're on some sort of a fasting thing. But I'm curious, there's kind of a dance here. So there are three things that are coming up. One is caloric timing, and does that matter? The other is caloric amount, and how does that matter? And then the third one is, how are we just saying calories here and not thinking about what are those calories? And so I'm curious what calories actually do better from a PCOS standpoint.
Well, like you, I don't encourage people to count calories. And I think what is important is to have an understanding with PCOS on how insulin levels long term, because really we don't want to just lower insulin levels for the next 12 weeks. We want to improve them for as long as possible, right. Which, lifelong. Note to self. And so cutting things out and doing things like the caloric manipulation with timing, I can totally see how that would do something to change it for the short term. But there hasn't been data long term, and we need to have better research that shows long term before it's recommended as a solution for people who are every cell in their body is being disrupted by PCOS, and they're feeling tortured doing this kind of stuff, And when I started listening more to my clients, what I found is that they were doing everything they were told, and they still didn't feel better. And then they felt really ashamed when it didn't work. And even though diets we know don't work for most people long term, so we need, as clinicians and researchers, we need to do a better job. And so when people come up with research like this, I'm like, okay, now take it to the next level. Let's study it for a couple of years and see what happens. And for so much of our nutrition research shows the short term it does something, but long term it goes back up, whether people stick with the diet or not, so it doesn't even matter if people fall off that wagon or whatever. I'm like, burn that wagon down. Yeah. Don't worry about staying on this wagon, because even if people stay on it or not, the insulin levels go back up, blood sugar goes back up, and weight goes back up. And so, restricting calories and manipulating them. The other thing that I really believe is unfortunate with PCOS is that we are prescribing the same thing that we call pathological in another group of people. So my clients with an eating disorder like anorexia nervosa, where calories are restricted and there's good and bad foods, it's why is that not okay? Yeah. But then we tell other people to do it. Yeah. So that I just feel an incongruence with, and I think is really important to keep in mind. What I do find for people with PCOS is that they probably need more protein than everybody else. They just probably do. I mean, I can't figure out a better way to say it, but because it's not 100% certain, but they probably do. And for some people, they may feel good.
More at one time, or is it just important that you're getting in that protein at whenever you're consuming?
Yeah. So it definitely depends. And as dietitians, Ashley and I are really used to being individual in our recommendations. And I find PCOS is so important to stay individual. Okay. And that's why I'm like, you probably just need more protein. Let's figure out for you what that means, if at all. And for people who are younger, or maybe their insulin resistance, or their insulin levels are lower, I find that having more protein first thing in the morning, not necessarily having less carbs or fat, but just more protein in the morning and then a couple hours before bed, seems to do something to help lower insulin levels and to be a really powerful tool for mood and cravings and things like that, and energy levels. Like a lot of my clients will tell me, I actually kind of want to move my body, and that is freaking me out. Like, I don't know what that means. Like, because exercise for so long,
exciting, like, wait,
horrible.
This is weird, you know, that like, it's developing.
Yeah.
So when we talk about protein, and we did just get a question on this, animal versus plant protein. So I'm a big hemp seed fan because I also love like wild salmon and some of these others. So when you're mentioning protein, are we beans? Are we quinoa? Are we, talk to me a little bit about, proteins, and then also, I guess the notion of like, protein powders and, that kind of like, are there preferred forms that what you've seen successful?
So I've definitely run the gamut of what has helped other clients, and what I have found overall as like a general kind of rule of thumb is that more complete protein tends to feel that has a better effect than ones that are not as complete. And this is something that I'm like, whenever I say it, I'm like, any vegetarian or vegan will cringe a little bit. And I say it just because I think information is power, but I find when people have more animal proteins, especially in that morning and bedtime, around bedtime snack, they notice it helping more. And it doesn't mean that a person can't be vegan. It doesn't mean anything like that. And it just may take longer to replete some of the inflammation that happens with PCOS. And so some of my clients end up deciding to include more animal protein because they do feel better. And they may not name themselves as a vegan anymore, but they just eat lots of vegan food. And I love how that's almost become a more trendy experience because then there's more flexibility. I have some clients, the hemp seed is something that makes them feel really energized. And then I have other people who are like, no, I need to have like chicken, or I need to have eggs. And it really just depends. And I have a feeling it has a lot to do with how malnourished people are. And I know sometimes when people hear the word malnourished, they think of someone who's really like skinny looking. And my clients with PCOS typically don't walk in looking in a way that some people would say looks malnourished. But when you hear about the diets they've been on for so long and the weight cycling and all that stuff, I'm like, yeah, your body's really malnourished. And so if a person's been through lots of diets and malnourished in some way, they'll find that it just takes longer to feel a benefit from it. And the other part of the protein piece I think is really funny as a dietitian is it doesn't have to be like quinoa or something fancy that is expensive. I have clients who will eat chicken nuggets and they're like, that makes me feel so energized. I'm like, go for it. Then that's
just
great.
Not the Tyson ones right now. We've got a food recall.
Well, thank you for being on with that one because I didn't know that. So don't eat anything that is spoiled or has a foodborne illness. That's the only bad food in my book, or if you steal it. But so it may not be as fancy, and I think that's really important. I think that makes nutrition more accessible for PCOS, and certainly more like fruits and vegetables is something that helps with inflammation. But if we don't help people get the tools to lower insulin levels, then that other stuff doesn't help, so, and people just feel awful. So like, let's help your body actually feel good. So that's my spiel on protein. So I don't know if you have any follow-up questions on that.
Well, and we're getting a couple of questions. So I got one on caffeine. So so she really likes caffeine. Okay. You like caffeine, and she did a prayer. She's like, I like caffeine. I'm like, yeah, totally. I was like, I'm pretty excited for you. Yes.
So what's the question about caffeine?
Are you in the, I'm assuming, a no or a yes, in terms of can caffeine be included? Oh, she tried to quit caffeine. That's what, okay. Yes. Didn't work well. Yeah. So
something that I know to be true with PCOS is that 75% of those with it probably have a sleep disorder. So caffeine is vital if a person's not getting enough restful sleep. And sometimes people know if they have a sleep disorder or not, whether that's been tested or they're like, I can never get good sleep. And sometimes people just don't know that they're not getting a deep sleep. And so if someone is feeling just like they need the caffeine, I think that's a really good cue to turn in and be like, I wonder what my body needs right now. And I do recommend every 3-ish years getting a sleep study done if you have PCOS, to see if you do have one, since it is so common, and treating it as something that's really helpful. What I know with PCOS and caffeine is that for some of the research I've read is that it can further enhance or increase insulin levels and like a long-term kind of thing, like relying on it. So I don't know. You're hearing me struggle because I'm also like, there's other things you can do first that probably will help. Yeah. And, including caffeine and like the 1 or 2 cups, that's like the general recommendation, will be fine for most people. And then I have some clients with PCOS who find they need to cut themselves off at a certain time, whether it's like 6 p.m. or 12 p.m. or something like that. So I would encourage a person to just experiment with it and see what works. And for that person who asked that question, and just notice how their body responds. The other part is sometimes my clients will use caffeine to keep them going. And my clients with PCOS are so focused. They can get stuff done and not eat. And so I would also want to question that part of it. Is caffeine something that helps you focus and then miss meals and miss self-care? Right. And if it's doing that, that could be another way to kind of help peel it back is it something that I'm using to help me focus? Yeah. And, I don't know. That's my 2 cents on that. So
I think it's great 2 cents. I always love when people are like, I don't have caffeine after 6. I'm like, oh my gosh, if I have caffeine after about 8 a.m., I'm on warp speed, So it's so personal, right, on that part. So one of the other areas when I was doing my doctor Googling and pretending to be a patient, there's a lot of conflicting information about what you should supplement and what you should get from your diet. And I don't, as dietitians, I don't think we really separate that, or we shouldn't. We're looking at total nutrition, and there are some nutrients that might be easier to get in through diet or easier to get in through a supplement consistently. But one of the areas that kind of came up as a flag in terms of needing to get in are your minerals. So I wanted to kind of walk through, I use, obviously the Better Nutrition program, we have the magnesium evaluation. I think it's so important when, 70% PCOS or not, 70% of women are not even meeting the daily recommended allowance for magnesium. But things like magnesium, chromium, potassium, how do you, are there recommendations where you say, hey, this is a nutrient that's so important, you want to make sure you're not just getting it in from food, but you might also want to get it in from a supplement?
Yes. And so there are a few different ones than you're mentioning, but when I see clients, initially, they usually are so depleted and malnourished that first as a dietitian, I'm like, let's make sure you're eating enough food, let's just make sure you have enough food there. And, some of my clients are binging, and doing behaviors that not eating enough will make it even swing more into the binging experience. So I'm like, okay, let's just eat enough so the cravings are not as enhanced. And then after that, what I like to do is I think there's 2 supplements that I recommend all clients with PCOS to experiment with. Because of the chronic pro-inflammatory state, my clients with PCOS are probably going to be deficient in omega-3 and especially DHA. And so my clients, after they take a DHA supplement or omega-3 supplement that includes a certain amount of DHA, after about 3 to 6 months, they notice their mood is better, energy is better, ovulation is usually better, insulin levels are coming down. And that's just because finally, all that oxidation and inflammation, that cycle that's just going over and over again, it's so much worse with PCOS because of the hormonal dysregulation. And so getting that extra DHA in there helps the body just not feel as depleted. So that's one I always recommend. And you can't get enough of it from food. A person would need a supplement. And then the other one is this really exciting one called inositols. And inositols is a part of B vitamins.
Somebody just interrupt us and can't just which supplement do you recommend, if you don't mind, you went back to the omegas?
I can go back to omegas. So what I recommend with that is an omega-3 supplement that is third-party tested. I'm not too picky. It has to be third-party tested, and then it also has to label how much DHA is in there. And many omega-3 supplements do not. They may have how much DHA / EPA is in there, but I would like to know exactly how much DHA is in there because a person would need 500 to 1,000 milligrams a day of that DHA in order to replete those levels. And so, even if a person finds a brand that works for them, like the Kirkland brand forever was one that we would recommend, but sometimes they catch different fish and they maybe don't know which fish they're going to catch this next season. And so they'll change the label and it won't have how much is on there, which is a bummer because that's the cheapest one per gram of DHA. Anyway, so that's one I recommend, and for the omega-3. So there's lots of different companies that fit that now. So before there was only 1 or 2.
just to clarify, so she's recommending, you didn't know about DHA, exactly. So when you're in your omega-3s, you've got your DHA, your EPA, your HPA. I personally love a wild salmon supplement. That's going to be more expensive. I love that you're mentioning Kirkland. And you can see the different brands, and more stores are moving to store-bought, or even if you go to a practitioner. So I think this amazing advice that Julie's giving is to make sure per serving that you're getting in 500, is it milligrams or IU? It would be milligrams, right? Milligrams of DHA, which is going to be one of the omega-3s. Now, there are also products that are just DHA. So she said thank you, and we've got all of that. Okay, so moving on. Good. So we talked about omegas. I brought up magnesium, but I'm curious what other nutrients you're focusing on.
So, yeah, because magnesium is interesting, but the one that is like the most excited one, I think all of us who specialize in PCOS and all the researchers are really excited about inositols. And inositols is a group of B vitamins that are secondary messengers, and there's probably 9 different types. And gosh, my biochemistry was over 20 years ago now, so it's like I feel like it's so far in the background now, but I'm having to get back to it, because what we know about inositols is, those of us without PCOS, inositols are kind of like if you picture a cell that needs energy, and as dietitians we always talk about insulin is like the doorman that opens the cell. Well, inositol is, if that hinge is kind of like stuck or something in that door, the inositol is a WD-40 that comes in and like helps open it. And there's 2 types of inositols that they're finding that people with PCOS are either deficient or have a defect in, and it's myoinositol and D-chiroinositol. And it's really exciting, because what we're finding is that taking inositols in the right ratio is something that helps improve ovulation. It lowers testosterone. It improves the cholesterol panel. Did I say lowers insulin? I don't think so. It does all the things that seem to be affecting PCOS. It may eventually replace metformin, which is like the ultimate insulin sensitizer that most people with PCOS are on. I'm sure some pharmaceutical company is going to get their hands on it and want to like prescribe it, and so it's going to cost $1 bajillion. Metformin, which is also an insulin sensitizer, but a prescription, it's only like $4 a month now because it's generic, so it's super accessible, but has horrible GI side effects. And only if someone has really severe IBS diarrhea type, they may find similar kind of effects with inositol, but that's the only group of people that I find have had like a negative effect to it.
And do you have a recommendation for, I'm getting 2 questions, a recommendation for the type or how to pick an inositol. So let's start there.
Yes. Yeah. Okay. So, I'm definitely not a brand loyal person, but unfortunately there's only one on the market right now that has the right ratio and is third party tested. If you have one that you found that meets that, oh my gosh, let me know, because I cannot wait to have another one. But there needs to be a 40-to-1 ratio of myo to D-chiroinositol, and the current one on the market is called ovasitol, and after this is over, I can kind of put it, like, and spell out everything for you in there so people can see, because I know it's like these weird big words. But
if you spell it right now, I'll add it into the comments.
Yeah. So it's ovasitol is OVASITOL.
Okay, great. And who makes it?
It's by Theralogics.
TEHRA, Logics. Okay, great. Okay, cool.
Yeah, so that is one that is third-party tested, and it's in a powdered form, and you mix it in some water, and there you go. And my clients tell me that they see themselves ovulating one of like a 28-day cycle. They're like, oh my gosh, I've never had this before. Like, you actually know when you get your period? Who has this? And excuse me. And ovulation's improving, so people are getting pregnant too, which is really exciting. Touching on that fertility piece, but also seeing hair growth be more what they want. And mood better. Like, that's one of the first things people notice.
One other question on here. I just want to, Roya, just while we're in this, Roya, were you asking how much is too much milligrams in terms of too much DHA, too much inositol, or were you asking about too much magnesium? So, Roya, if you can let me know, if you have questions about magnesium, we'll tackle that on a whole separate one, or you can go to the Facebook Live that I did on, I forget what day we are, on Wednesday night on the Blendaholic on Facebook, because I talked a lot about magnesium and which kinds there. And if it's a question about how much is too much DHA, too much magnesium. Okay, Roya, I'd send you over to the Blendaholic Facebook Live. The one comment with magnesium is if you take too much magnesium, your bowels are going to tell you first. But I usually keep people to about 200 milligrams in a day, unless there's a reason, unless you're working with a practitioner to go up from that. But 200 milligrams could be too much for someone. If you notice you get loose stools, then we want to pull back from that part. Great.
Yeah, and it's interesting because people with PCOS, the IBS is really common with PCOS, probably because of the inflammation.
Yeah.
And some people are chronically constipated, so I think they would welcome that from magnesium. They'd be like, "Thank you, I could probably go to the bathroom."
Well, I actually that's great, and I know as I said, I could talk to you for like 3 hours about this. You guys, I'm so excited. Julie is sharing here with you, and I'll share it when we promote the video, and also when we have it over on YouTube. So you'll have the link to the video if you want to share it with anyone, or even share it with your practitioner. Hopefully your practitioner loves to learn, and so we all love to learn from true experts. But one of the things she's also sharing with us is her PCOS roadmap. So you can actually, what are these first 3 steps? But I can't let us go without talking about the digestive part. Anyone who knows me knows that's at the core of everything. I really, one of the things that struck me when I was doing as I said, like my Dr. Googling and some of these commentary was just how much the medications, even leading up to things that you might have tried going into a diagnosis, or certainly trying things once being diagnosed, how tough they must be we know them to be on digestive health, whether it's on impacting the microbiome or on potentiating leaky gut, if you've got, some of these birth control and some of the others. So I'm wondering, do you recommend for people to do sort of a digestive tune-up with you, sort of at the start, or how do you address digestion in that space? As you're mentioning, a lot of people have that issue.
They do. IBS and just GI stuff, bloating, cramping, just not having a good time in that department is really, really common. And it's funny because of like, what is it connected to PCOS? Like everything is. And something that I appreciate is that I'm not a GI expert, and I see clients with it. And what I find is that when people start to eat enough, that some of the symptoms start to go away. That kind of chronic dieting and restricting leads for so many people to have the disrupted GI tract. Like dieting and restricting can lead to IBS, and so healing through eating enough, and sometimes having something that can, like some medications that can help it, or supplements that can help it. If people need more than that, I actually, Beth Rosen is a dietitian out of Connecticut who sometimes my clients will consult with her and go through a FODMAP thing or something like that if IBS is more of their primary, and then they come back to me. And so I think the part that like metformin is such a common medication that it ends up tearing up so many people's GI tract. And it's really one of the only things that people are offered. So they just kind of deal with always feeling that horribly. And thankfully, again, inositol is something that people can kind of try to use instead. But yeah, so to answer your question, I feel like once people are eating enough, and that seems for the majority of my clients to start to repair, not fix it, because I know the microbiome takes years to get to a place where it's up and running in a healthy way. But just moving away from diets and like torturing their body it helps for most people to do what they want to do, so then they can poo like normal. That's always awesome.
You got to be able to eliminate. So I will put in anyone that I put on metformin, I also have them on a glutamine, just to make sure that we, in trying to, and probably a probiotic. But you guys, if you want more about that, you can grab the Better Digestive tune-up, or do the digestive evaluation and take that into your practitioner, so that you don't just guess what's going on with your digestion. All right. So in closing, I just want to, I think it's so. I'm going to go back to kind of what we started with and what you said about, you did all this work. You're like, my clients aren't lying to me. My patients aren't lying. I had to learn about it. One of the greatest challenges, I think, for people who may be finding this or who are doing the Dr. Google, and I even went into Reddit. I went deep into Reddit and read a little bit about what people are saying, is they're really struggling because they feel like their practitioner doesn't believe them. So we're a world away from solving like all of the things that need to happen in healthcare. But any tips on how to develop that relationship with your practitioner, so that or, maybe my tip would be like call Julie and have her, write a note to your practitioner. But, how do you help people, take that first step forward when they're not able to have that conversation with their practitioner?
Yeah. So if a person's feeling like they're not being listened to, they're not being seen or heard, first, I want to apologize because that stinks. Like, you shouldn't have to experience that getting healthcare. Like, everyone should have access to, like, comprehensive, dignified healthcare. And so advocating for yourself may be really hard, and you may not always have to, or may not always have the energy to do it. And if you can't do it, that's okay too. I feel like people just need to, like, if you can't do it, it's not your fault. It's because these are big systems that are oppressing us. And so, whatever you can do to find a support is really helpful. But there's also things that you can do to tell your practitioner, like, listen, I have tried all of these diets, or I've tried all these different things, and I still don't find getting any better. I'm not willing to go on another diet. I want you to find another thing. Like, what do you tell your clients with PCOS that are not at a larger weight? What do you tell them to do? I want to hear that information. And for a lot of people, that right there, that piece helps a doctor to kind of shift enough, or the dietitian to shift enough just to give them some different information. Reagan Chastain is a blogger. She's also someone who's like an Ironman triathlete person. I didn't say the right thing because it's like Ironman is a triathlon, but anyway. But she's someone.
Ironman is an Uber triathlon.
Yeah,
right?
there you go. Yeah. But she's someone that has even like written out like a script that you can take to your doctor if you feel uncomfortable. I know I get so nervous. My heart rate is always so high when I go to the doctor. They have to take my blood pressure so many times. And I've like worked in hospitals forever and I still get nervous. But so if you feel that way too, she has scripts in her blog that you can say. And if you just Google her name and
that's awesome.
yeah, and you'll find her little scripts. And so you can just literally take that. I have some clients who send an email because, all those portals that we now have, and they just say, hey, I just want to let you know I'm trying to heal my relationship with food, or I'm trying to heal binge eating disorder and dieting makes it worse. And, can you help me find some other things besides diets? And if they don't respect you and you have access to finding someone else, I hope you do it.
Yeah. Yes, Candace was right there with you. She said it's hard because some don't listen. It's really hard to find the right doctor. I think it's a plug for Julie and just a plug for dietitians who are moving in this space. Because, and maybe this is just me growing up with doctors. So I say to my dad, I adore him, but he's a surgeon. I said, maybe their job isn't actually to listen. Like, what you can turn to your doctor for is help with the diagnostics, and then you can turn to the person to build the plan with the person that can listen to you and really talk to you about your life, and what's going to work for you. But that does take a little bit of a thicker skin when you're, or developing that thicker skin when you're in with your doctor than, of just being like, I'm here to get diagnosed. I'm here for the diagnostics. I'm here, for that part. So many amazing resources. Julie, thank you so much. I'm really excited to share this, out wide, and I think it's going to be really helpful information. I have a lot of fitness professionals that have struggled to engage with their patients because they see their patients doing the workouts, as you said, like they're really committed and doing that part. So if you're a fitness professional listening to this, please, Julie's got some great tools on that part. And certainly if you guys have any questions, you can get, and I'll include all of this, but you can get to her at juliedillonrd.com. I'm so grateful we connected. So thank you for sharing your wisdom today.
Thank you, Ashley. It was such a good time.
Yay. Candace says thank you too. You're welcome.